Onc Live Insights is a video editorial program produced by Onc Live.
If I'm facing a patient who fits either in the category of favorable or intermediate risk, Memorial Sloan Kettering algorithm, I think that the data are convincing that both the combination of bevacizumab plus interferon is excellent, Sutent in first line is excellent, pazopanib is excellent. I personally don't think that high-dose interferon has a place. I would say that high-dose IL-2 certainly in first line has given complete remissions and in my view led to cure of these patients. But when choosing between high-dose IL-2, Bev plus interferon, sunitinib or pazopanib, I think that the differences between the countries and the way the medical system is set up come into place. So for instance, in my country, in the Netherlands, we tend to use the oral drugs. Bevacizumab needs IV administration every 2 weeks and 3 weekly interferon administration. I personally find it a little bit more cumbersome to treat patients with that combination, but I do have patients who received the combination, who for whatever reason went off treatment and still years thereafter are still in remission. So I think it's an excellent choice. But personally, depending on the situation, I think that a lot of doctors will probably choose between sunitinib and pazopanib. When you then consider the data, I think we have excellent data for, like I mentioned, all these treatments. But if you compare sunitinib with pazopanib, there are distinct differences in toxicity. There was a trial called the COMPARZ trial. This is a large trial, over 1,000 patients. It's a randomized trial. It's not a superiority trial, but it was a trial to investigate non-inferiority of pazopanib versus sunitinib. And interestingly, the trial was positive in the sense that non-inferiority of pazopanib versus sunitinib was demonstrated in this trial. But the trial also gave the opportunity to investigate differences in quality of life, tolerability of the drugs. And so it gave a great opportunity to really look from the angle of the patient. And interestingly, a number of instruments were used: a fatigue score, a kidney symptom index, a cancer treatment satisfaction score, quality of life questionnaires were used, and patients responded and filled in the questionnaires. And from that investigation and assessment, it became very clear that pazopanib has a very favorable profile as compared to sunitinib, although there are certainly differences. So for instance, if you look at the hematological toxicity, it's clear that pazopanib does better than sunitinib. However, if you look at hepatotoxicity, elevation of transaminases, it's clear that this is more typically linked to the use of pazopanib versus sunitinib. So we really have to be aware of the differences. There are differences, but if you look at various of the adverse events that occurred in more than 10% of the patients, the list of adverse events in favor of pazopanib was far larger as compared to the list of adverse events that were favoring the use of sunitinib. Now, fatigue was something that was really outstanding. Fatigue was all patients after treatment immediately had a problem with fatigue, but with the pazopanib treated patients, the fatigue, it improved, while the ones on sunitinib remained the same. So if you look at all the questionnaires about quality of life, etc., it became clear that pazopanib is, from a doctor's point of view, easier to handle, and from a patient's perspective, better to tolerate. Mind you, I think that it's very important to be aware of the fact that the liver toxicity of pazopanib stands out as compared to the hepatotoxicity of sunitinib. So we do have to be very careful and monitor on a regular basis in the first 4 months the levels of the transaminases and also respond to elevation according to an algorithm that is available. And it's important to say that the hepatotoxicity is reversible. It is manageable, but you really, as a physician, you have to be aware of these changes and monitor, and in particular in the first 4 months, because all the hepatotoxicity, almost all of the hepatotoxicity will occur within the four months, and they are reversible. So I think that COMPARZ gave us a nice insight of head-to-head comparison of 2 TKIs with similar kinase inhibitory activities, but certainly, and that's probably based on the fact that they don't only inhibit VEGFR1, 2 and 3, but these are promiscuous drugs that also they inhibit other kinases, and that probably explains the differences in adverse events and the differences in tolerability. So it's really a nice study comparing head-to-head 2 powerful TKIs. It was very helpful for physicians. There is another trial run in France that was really a very unique trial in its design. And the doctors, in essence, asked the question, now that we do have 2 TKIs that look very similar for frontline treatment of metastatic RCC patients, wouldn't it be important to assess whether patients do have a preference for one drug over the other? So they designed a study in which both drugs, it was a double-blind randomized study, both drugs were given for a period of 10 weeks, then there was a washout period of 2 weeks, and then there was a crossover to the alternate drugs. So patients who started on sunitinib went on pazopanib, but as I mentioned, patients and doctors were blinded for what they received, and the other group started on pazopanib and then crossed over to sunitinib. And so this design enabled them to ask questions to patients about which drug X or Y they preferred, while still not knowing what drug they really received in the first period as opposed to the second period. And it's quite a neat study in terms of the data that emerged. Sort of a surprise perhaps, 70% of patients had a clear preference for pazopanib. 8% did not have any preference, and the others had a preference for sunitinib. So a smaller proportion of patients favored to have being treated with sunitinib. Most interestingly, also the doctors, who were also blinded, had to answer what their preference was, and also the doctors had approximately 70% of doctors who preferred pazopanib over sunitinib treatment. So the difference in patients' preference for pazopanib versus no preference was statistically clearly meaningful. And looking at these PISCES data and also the breakdown of why patients preferred pazopanib, in most instances it was not one single factor, but if they had to single out a factor, it was quality of life, the fatigue, which was less, so they felt much better. And I think that this quite innovative trial, although it's a smaller trial, but it's very clear in its answers, is very important for us as doctors, because this is a chronic treatment and we have to be aware of the fact that if we're not going to cure patients, at least in 2015, we might be hoping maybe with newer drugs that we might be curing in the future, but at this moment we're not going to cure patients with metastatic kidney cancer. We're going to chronically administer drugs to them. It's very, very important that when they're at home, that their quality of their life is as good as possible. So I do think that PISCES really supported, in a way, the COMPARZ data, but from a very nice, it was investigated in a very nice way, and I think that we have to take into account that patients also may need to vote on what drugs they would like to get in first line. Now that we have the data of COMPARZ as well as the data of PISCES, how do you, did it change your patient management? I think it does. I think initially I tended to believe, and I presume most of the colleagues, that sunitinib may well be a more powerful drug, more efficacious. At least patients with large tumor volume or liver metastasis, for instance, I would tend to prefer sunitinib as opposed to pazopanib. But now that we have the COMPARZ data with showing non-inferiority of pazopanib over sunitinib and no clear difference in efficacy of either of the two drugs as compared to the other one, plus the PISCES data showing that there's a preference of patients in favor of pazopanib as compared to sunitinib, and they could really compare because they received both types of drugs. I do think that at this moment there's not really, you cannot really say that you should use sunitinib in all patients. So I tend to give more and more pazopanib because I think that it's a relative easy drug. You have to monitor liver toxicity, and usually the side effects are less cumbersome as compared to sunitinib. Although I must say that there are certainly patients who have lots of toxicity on pazopanib treatment, and there are certainly patients who tolerate sunitinib very well, and they like to have this scheme of 4 weeks on and 2 weeks off. So in daily practice, sometimes you really have to try and see how it goes, because the patients are all different. We tend to think that, oh, they're all metastatic kidney cancer patients, but there's differences in the background of the patient. So I think that still all the treatment options are there. It's also whether the doctor feels very comfortable in prescribing a specific drug or has more experience in dose management, side effect management, because the side effects differ. But there will of course be some preference of doctors, and there's certainly, based on PISCES but also based on COMPARZ, trend, I would say that pazopanib is being the preferred drug preferred by the patients.